Hello, ladies and gentlemen, and welcome to Traumatic Brain Injury and the Criminal Justice System, a review for forensic and legal professionals. My name is Darian Buell. I am the Executive Manager with the American Institute for the Advancement of Forensic Studies. We commonly use the acronym AIAFS, which you may have previously heard. I'm so pleased to be with you today and to have the opportunity to introduce our guest presenter, Jared Brown. He's a real standout in the field of forensic mental health and has a great understanding of traumatic brain injuries. Jared has made remarkable strides in expanding education within the areas of forensic mental health. He's also written several articles which can be accessed online for free at Forensic Scholars Today. He's currently the Treatment Director at Pathways Counseling Center Incorporated, located in St. Paul, Minnesota, and is the founder and Chief Executive Officer of the American Institute for the Advancement of Forensic Studies. Finally, he's just an all-around fascinating person, and we are truly in for a treat today. Without further ado, please join me in welcoming Jared Brown.
Thank you, Darian, for the introduction, and thank you, everyone, for taking the time out of your day to listen to today's webinar presentation on traumatic brain injuries and the criminal justice system. Here is my brief biography that Darian just read to you. If any of you ever have any questions, comments, concerns about today's webinar presentation, please feel free to email me at the email address below on this slide. Here's a training description of some of the major contents that we'll be covering into today's webinar. And we're going to be covering at least three main key objectives today. First of all, we're going to analyze and go through a number of the key research findings related to traumatic brain injury in the criminal justice system, and all of you will hopefully become more familiar with some of the concepts associated with brain injuries within criminal justice and forensic settings. We're also going to discuss some of the challenges and the benefits of routine screening for TBI within these settings. And then hopefully all of you will walk away with a better understanding of some of the core deficits and secondary disabilities that might come into play as a reason why someone with a traumatic brain injury would become involved in the criminal justice system as either a defendant, a witness, a suspect, or someone spending time within a confinement setting. Today's agenda is broken up into a variety of subheadings. I'm going to spend a little time on brain injury basics, but I'm going to assume those of you who are listening to today's webinar have a general idea of what brain injury is, so I'm not going to spend a great deal of time on the basics. And then we're going to be moving into some of the related consequences associated with TBI, and then moving into various criminal justice, criminal behaviors, various problematic behaviors that may result as TBI may occur, and then also have a discussion about the impact of TBI within correctional settings, and then move into screening and intervention considerations. I also put a number of supplemental slides in today's PowerPoint at the end of the conclusion section. We will not have time to cover those slides, but they are supplemental slides for all of you to review on your own time. Just to give all of you a brief understanding of where my professional experience comes from, I've worked in the field of mental health for 15+ years. Most of my experience involves working with adults with these various disorders, but I've also had various other positions working with juvenile offenders, juveniles within mental health settings. I've also done various probation types of positions as well. So my lens is really through the mental health and the criminal justice systems. I also do a lot of research in the area of traumatic brain injury, fetal alcohol spectrum disorders, among other things. And I also do various teachings and trainings, and I occasionally do consultation on some of these topics as well. So just to provide all of you with a basic broad overview of brain injury in general, for today's purposes of today's training, we're really going to look at acquired brain injury. So this is a type of brain injury that happens after birth. So we're not going to focus on any type of prenatal trauma during today's presentation or fetal alcohol spectrum disorders. but it's mainly going to look at acquired base brain injuries. It's important to keep in mind that the overwhelming majority of brain injuries that we're most likely going to see within the criminal justice system fall along that mild spectrum. But it's important to realize that even though it might be a mild brain injury, it can result in a host of adverse consequences that can lead to lifelong disabilities in some cases as well. And I'll break that down for all of you in a few minutes as well. It's also important to keep in mind that there are various severity levels associated with TBI, and they're broken up into 3 domains. You have mild, moderate, and severe. The symptoms of TBI can range from little to no symptoms all the way to death and everything in between. In some cases, it can also result in a partial or total brain disruption. You can even have alterations in brain functioning. A lot of individuals I work with have experienced a concussion, which would be more on that mild end of the spectrum. You might also hear the term post-concussion syndrome, and that is something just to have a basic understanding of, to be aware of, because you will encounter some individuals who are involved in the justice system that have experienced this. Some of the symptoms you might see if you're a corrections professional, a probation officer, or even a forensic mental health professional, if someone has post-concussion syndrome, fatigue is very common. The person may complain of headaches or dizziness. You might see an increase in anxiety or irritability. They could show an increase in sensitivity to light or sound. They might show a host of cognitive symptoms. So keep all of that in mind too if you're assessing or evaluating someone who you suspect had a history or a recent traumatic brain injury. It's also important to keep in mind that there's a lot of misconceptions about brain injury in the literature, and part of this relates to terminology indecisiveness. In some of the literature, you might see traumatic brain injury referred to as a minor head injury, or a minor head injury, or mild head injury. You might even see it called a traumatic head syndrome, or it might be called mild concussion syndrome. But keep in mind, for today's training, we're going to call all of this just traumatic brain injury in general. When we talk about mild traumatic brain injury, depending on what literature you look at, research findings, I've seen anywhere from 75 to 85% of all types of brain injuries fall in that mild brain injury domain. What's interesting is a number of people in the criminal justice system who are serving time within a correctional setting don't always come in with just one traumatic brain injury. They might come in with multiple head injuries, minor head injuries that have a cumulative effect over the years. So one head injury by itself, treatable in a number of cases. They might be up to functioning within months or sometimes years. But if you add another traumatic brain injury on top of that and another one on top of that, it has that cumulative effect that can result in even more severe and lifelong deficits. There's a lot of issues with detection of mild brain injuries as well in the criminal justice system, because a lot of times individuals who sustain a mild head injury may not realize that they even had a head injury. They may lay on the couch for a few days and sleep it off. They might not seek medical attention. They might deliberately not seek it because of domestic violence. They might not seek it because they lack the knowledge and recognizing that they do have a head trauma and they should get medical attention. In some cases, denial on part of the individual who sustained the head injury might be a problem too. In a lot of cases, there's symptom overlap as well with a head injury with a host of other mental health, neurocognitive disorders. So it's difficult to tease apart really what's going on. And in my experience, there's a number of criminal justice professionals that just lack the awareness and training on traumatic brain injuries. So again, I commend all of you for listening to today's presentation, where the goal is obviously to educate and help criminal justice professionals become even more aware of this very important and complex topic. When you are working with someone you suspect has a traumatic brain injury, or doing an evaluation or an assessment or screening protocol, it's also important to keep in mind their mental status changes. There's a number of different deficits or changes that you might see that relate to cognition. Again, increased risk of agitation. They might even have an altered state of consciousness. In some cases, you might see various forms of amnesia, short and long term. The person may demonstrate apathy. They might have a number of behavioral disturbances. In some cases, they might confabulate, which I'll talk about in greater detail in a little while. You might see the person having increased confusion. They might not have awareness of their surroundings, or that they may need to seek medical attention. They might have the inability to concentrate. They might seem very indifferent, and they just don't seem to care that they had a brain injury, because in fact they might not know they had one. Memory recall is a huge issue in some cases. And keep in mind that substance use, alcohol and drug use, often co-occur with traumatic brain injury. So it's very important to keep in mind the mental status changes to be aware of. The number of authors and academic researchers that call traumatic brain injury a silent epidemic. I've seen it referred to as a hidden disability. A number of the deficits might be invisible as well. It's important to keep in mind that as many as half of traumatic brain injuries, depending on what research findings you look at, go underreported. So it's very difficult to know how many people truly have a traumatic brain injury in the United States. But based on available research, a high percentage of these individuals kind of fly under the radar, and even fly under the radar once they enter the criminal justice system, which is so important to really start detecting this, because if someone has a traumatic brain injury and is trying to navigate through the criminal justice system, it can lead to a number of consequences, issues of competency to stand trial, issues of Miranda right warning, just understanding their basic rights. There's a host of statistics that you'll find in the literature. This is just a snapshot of some of them. Just to keep in mind, TBI is a worldwide problem. There's one research finding I found that almost 60 million people worldwide have suffered a traumatic brain injury. In the United States, 3 TBIs occur every minute. It's also important to keep in mind that personality changes can occur as a result of traumatic brain injury. In fact, as many as 25 to 35% of people that have sustained a brain injury may also experience personality changes. Interestingly, males are twice as likely as females to sustain a TBI. And interestingly, too, I came across an article that discussed that males are 3 times as likely than females to die from a TBI. There are many common causes of brain injury. There's accidental, there's incidental, and there's deliberate acts. And this, based on what category you're looking at, TBI can result from sporting-related events, slips and falls. They can relate from various forms of violence, child abuse, domestic violence, you'll sometimes motor vehicle accidents. Strangulation could result in a traumatic brain injury if domestic violence is going on, if someone had a stroke or aneurysm or a near drowning or attempted suicide. Even drug abuse can lead to a traumatic brain injury. Certain infections, if someone was poisoned, combat-related history, gang involvement. These are just some of the reasons that may result in a traumatic brain injury. So if you are doing a screening protocol, I would start collecting a long list of possible variables that could increase the risk of TBI in the individuals you are screening. So what are some of the risk factors? These are just some of the ones just to keep in mind. Obviously, poor decision-making, substance misuse, learning disorders. I think it's important when we talk about substance misuse is to really identify what substances does the person use. Is someone drinking a liter of vodka a day? Is someone using inhalants or sniffing spray can paint? Or are they using marijuana? These are all things to keep in mind that could have a variable in determining the severity of a brain injury. Family dysfunction. What kind of dysfunction is going on? Is there abuse going on? Is there abuse history? Is there a history of prior traumatic brain injuries? Interestingly, a major risk factor is if you have a prior head injury, you're much more likely to sustain a second and subsequent brain injuries after that. Is there any history of antisocial behaviors or criminal justice involvement among the individual that places them at greater risk for a brain injury? Again, have they served any time in combat, athletic participation? Have they been in sports where they've sustained a concussion? I think it's also important to keep in mind that risk for TBI goes up among certain age groups. The age groups that are most susceptible to a brain injury are newborns to the age of 4, 15-year-olds to the age of 24-year-olds, and then older adult elderly populations. Also, I think it's important to ask too, does the person have any pre-existing illnesses or conditions that put them at greater risk to sustain a head injury? Interestingly, with some of the clients I've worked with too, is a lot of them don't have a fear response, so they really engage in a lot of thrill-seeking behaviors. So I think that's another question to ask as part of a screening assessment protocol is, does the person have a fear response? And if not, what are their types of risk-taking behaviors? And have they ever sustained a head injury? What are some of the factors associated with unfavorable outcomes? Again, some of this is common sense, increased risk of substance misuse, even prescription medication abuse. Keep in mind misdiagnosis as well. If they're not getting properly diagnosed, it might be unlikely that they're receiving the proper supports, services, and treatment. Sleep is a huge issue with this population. Someone sustains a traumatic brain injury, sleep complaints occur in a large percentage of these cases. So it's important to make sure to help the person regulate their sleep and get plenty of rest as well. Does the person have a number of other psychiatric disorders associated with the traumatic brain injury as well? Does the person isolate? Do they have lack of motivation? Do they forget to take their medications? What about learning disorders too? I think it's also important to go a little deeper on this too, is do they have any attention or memory issues that get in the way of helping them go to treatment, helping them reach out and ask for help, helping them take that information they learn from their doctor or their case manager, social worker, or therapist, and utilize it in everyday life. Also, it's important to really take into account is what's their adaptive functioning and executive functioning capabilities. In a lot of cases, people with traumatic brain injury will have deficits in those various domains. A lot of the clients I work with are on some form of state-based insurance, high percentage of traumatic brain injury, and have a lot of supports and services in place. In some cases, memory is a major issue with the clients I work with, and especially with clients with traumatic brain injury. And this can have a snowball effect where maybe they forget to turn in their paperwork to keep their medications or keep their insurance going, so then they can go to their psychiatrist and get their medications. And I've seen this happen in some cases where it does have that snowball effect where they forget to do that and they start losing service providers because they no longer have insurance. So it's important to get good structure, good supports, good reminders in place for these individuals. Also, is there any housing instability going on? I think this is a very important aspect too for recovery for people with brain injuries, is to make sure they have stable housing and living environments. And are there any transportation or navigation issues that prevent them to get to their appointments that help them be more successful after sustaining the head injury? So as we move into some of the TBI-related consequences, there's a host of them. They're many and varied. You have physical, cognitive, affective, social, adaptive, behavioral. I think it's important to also just have a brief discussion. If you look at the literature on traumatic brain injury, you'll see post-traumatic amnesia be talked about quite often. I think this is important just to talk about what is post-traumatic amnesia. Some of the symptoms you'll see associated with this, and a lot of times after a head injury, and depending on the severity level, the person can sustain short or long-term amnesia. This could result in a loss of memory or just difficulty recalling certain pieces of information. You may see the person have an increased confusion, agitation, distress, anxiety. You might even see the individual have just uncharacteristic-like behaviors. In some cases, depending on the severity of injury, they might have an inability to recognize people who are familiar with them prior to the brain injury. And from a law enforcement standpoint, in some cases, depending on the severity, and if there's substance misuse involved as well, you may see the individual wander. And I've had a few clients who I suspect they've had a head injury in the past, they've been intoxicated, and in some cases they might not have been intoxicated, where they have some form of sensory deficit, visual spatial deficits, where they walk across the street and they look both ways. They see a car coming, but they think the car is 2 blocks away. They walk across the street and they get hit by the car, later to learn that the car was 10 feet away. Sometimes depth perception might be off. I've had a number of clients with a history of head injury who have fallen off bikes and hit their head. Now, I wonder if some of that might be related to sensory or visual spatial depth perception. Just something to consider when we're working with this population. Now, if you remember back, I had a brief discussion about executive functioning. This is a huge issue with people involved in the criminal justice system. Our prisons are full of individuals that have executive functioning impairments. They might have deficits in establishing appropriate goals. They might have deficits in problem solving. In some cases, they might have difficulty with planning and prioritizing certain things. You'll see this as well. They might have difficulty regulating their emotional responses. They might lack emotional self-awareness, where they might blurt out an answer in an area where they shouldn't be talking loud. They might not be very good self-advocates, where they can go to their doctor or their family member support team and ask for extra help. You might see someone with executive functioning deficits have issues in motivation. They might seem very lethargic. They might seem almost lazy. Sometimes they might have difficulty focusing. They can easily become overwhelmed. Their processing speeds can be diminished in some cases. So these are all various domains and deficits to keep in mind. By no means someone with traumatic brain injury would have all of these deficits, and in other cases, maybe they will. So it's really a case-by-case basis, but it's important to really screen this out, I think. When we have a discussion about executive functioning, it's imperative that we also have a discussion about adaptive functioning. So this is really, how does the person deal with their everyday affairs? How do they deal with everyday challenges and problems? Can they meet the demands of social responsibility? Do they have deficits in daily living skills? Can they live independently? Are they socially responsive? How do they communicate? Do they communicate effectively? Social participation, academics, occupational functioning. Just really deficits in everyday performance. So these are some of the domains to really keep in mind too when you're screening and developing goal plans, treatment plans, intervention strategies for someone with a traumatic brain injury. And again, depending on the severity of the injury, they may also have deficits in adaptive functioning. So traumatic brain injury and memory, huge issue. Briefly talked about that as well. This can lead to caregiver and professional frustration. This can also lead to client frustration. It's common. It can be sometimes short-term memory, long-term. I've seen it both. It might lead to an increased risk of confabulation. It may also be a variable to consider if the person is gullible or suggestible. They may be a very poor reporter or historian. Consider the impact that anxiety and sleep problems and depression and substance misuse have on this as well. It's only going to exacerbate the problem if they already have memory deficits. Consider the impact on probation requirements or court-ordered treatment. Consider if the individual is involved in the child protection system. What implications does that have for them parenting effectively and following court regulations and guidelines and rules? And if they're in treatment, do they struggle with staying compliant and following through and completing successfully? It's very important for treatment providers to become traumatic brain injury informed, because a high percentage of the individuals they see as well, especially in outpatient mental health or substance use settings, probably see people with brain injuries on a semi-regular basis. Social skill deficits is another major issue as well. In some cases, you may see the person, they may appear to be rigid, or they can be irritable at times. They might have difficulty with perspective taking. In some cases, they might have a very difficult time establishing what is a healthy relationship. You might see the individual have a lot of superficial relationships where they're being taken advantage of, or they don't understand stranger danger. They may not pick up on certain nonverbal cues. They could lack common sense. They might have a very difficult time telling other people no. And in extreme cases, I've seen this in some cases, it may lead to unwanted sexual advances, harassment, violations of no contact orders, and they might just have an overall difficult time detecting risky or dangerous situations or people. So these are just some other variables to keep in mind when you're working with folks that are at risk or have sustained a head injury. So now as we move into traumatic brain injury in the criminal justice system, there are many disadvantages that someone with a TBI may go through as they're trying to navigate the justice system, depending on what facet they're involved with. Again, if they're on probation, they might have difficulty complying with rules of probation because maybe they're not understanding it because of certain memory issues or some of the other deficits I've discussed. If they're required to fill out certain court-related forms, they might have a difficult time doing that as well. They might have a difficult time following through with reporting requirements or responding to orders or conditions of release. So anyone within the criminal justice system should really take this into account when they are working with someone with suspected or confirmed brain injury. Keep in mind, all of the deficits that I talked about could increase the risk of someone with a TBI to become involved in the criminal justice system. So just a brief review. Consider how adaptive functioning or executive functioning deficits could lead to this. Again, if they have social skill deficits, that could definitely lead to involvement in the justice system. Is the person impulsive? Do they have difficulty with judgment and reasoning or linking cause and effect? Do they have a hard time generalizing information? Again, the memory deficits, are they more suggestible? Is there substance misuse involved? Motor skills, you might see this as well, where they might have balance or control or coordination issues. This could lead to an increased risk of victimization, or this could make the individual appear to be intoxicated when they're not. My thoughts on the topic, it's a widespread problem. If we're working with folks in the criminal justice system, it's likely that at least half, if not more, depending on the research you look at, have sustained a head injury at some point in their life. It's also important, I think, to become trauma informed because such a high percentage of these folks have also dealt with various forms of trauma throughout their life, especially when we're talking about criminal justice populations. And I think it's really important to start getting TBI on our radar if you're working in any capacity within the criminal justice system, forensic mental health world, legal system, and even mental health community. So as I keep stressing the importance of becoming traumatic brain injury informed, if any of you are working in any of these settings, it's important, I think, to learn as much as possible about today's topic. And I'll take it a step further. If you're working anywhere within the human service sector, social service, or mental health world, there's no harm in becoming very knowledgeable about this topic because you will see people with brain injury on a very regular basis. So what are some of the forensic and legal considerations to take into account? Now, these are just some, but consider the impact on civil matters or tort cases, or even in some instances, wrongful death suits. Civil commitment may be a factor to consider. Does the person have a history of detox admissions because of ongoing substance misuse? Is there issues with medication compliance? Do they put themselves at risk or the community at risk when they're not on their certain medications? And again, if there's a child protection matter involved too, consider the impact that may have on just involvement in that system as well. Now, if you're working in the criminal justice system, I believe you play an intricate role in helping prevent ongoing consequences, and in some cases, just ongoing traumatic brain injury if they run the risk of ongoing injury because of fighting and impulsive behavior and substance misuse. I think it's important to routinely screen and assess folks in the criminal justice system for possible brain injury, because if we can detect it as early on in the criminal justice process as possible, hopefully we can implement the appropriate support services that can help that person be most successful, get out of the justice system, and not go back into it. Again, needless to say, brain injury is one of the most common disorders that professionals are going to confront if you're working in the criminal justice or forensic mental health settings. Unfortunately, a very high percentage of these individuals have never received the official diagnosis. I think they come in a lot of times with a long list of other diagnoses where their symptoms may fit the diagnostic criteria, but is there something that better explains why they have all these symptoms? And I think the longer list of diagnoses someone has, especially if they have multiple service providers and every time they go to a service provider they get a new diagnostic label, I think it would be important to at least consider the possibility, was there a history of any type of brain injury as well? Again, a lot of stats as well on criminal justice related TBI matters. There's over 2 million folks in various forms of confinement settings in the United States. And there's over 5 million folks on some form of community supervision or probation. Now, if we look at the statistics here, I've seen it range, but let's just consider it's 50%. That's a huge number to keep in mind. And then depending on what research literature you read, the most common causes for traumatic brain injury in criminal justice populations involve assaults and gang fights and motor vehicle accidents. And I talked about this earlier, but just want to remind all of you that the research has indicated too that criminal justice populations are more likely to have sustained, in some cases, more than one traumatic brain injury, in some cases, multiple brain injuries. And again, it's always important to consider the impact of substance misuse and antisocial behaviors and impulsive behaviors when we're talking about criminal justice populations. When we talk about substance misuse as well, I think it's important, especially if you have a client who has been a chronic misuser of alcohol through their life, history of homelessness, multiple detox admissions, to consider the possibility that maybe the individual is also dealing with Wernicke's-Korsakoff syndrome. Wernicke's-Korsakoff syndrome is outside of the scope of today's presentation, but it's something to consider when you're working with someone with a long, long history of alcohol misuse. As we move into the juvenile delinquency, a lot of variables to keep in mind. TBI is overrepresented among juvenile delinquency populations as well. But I think some of the variables to keep in mind if you're screening or working with juveniles that you suspect have a TBI is really to determine, was there a family history of violence? Did they experience any child abuse? Or was there any gang involvement? And if so, what's their level of trauma and attachment issues and history as well? All of these variables not only increase the risk of becoming involved in the justice system for delinquent behaviors, but I think it also increases the risk of victimization on these individuals' parts as well. Again, I look underdiagnosis as well, misdiagnosis. I've worked with kids before in mental health settings, and I was not TBI informed multiple years ago. If I could go back in time, I think I would have done things a little different with certain populations I work with. There's a number of kids I worked with in the past that came in sometimes with 5, 6, 7+ diagnostic labels. The common ones, obviously, ADHD, conduct disorder, reactive attachment, FASD. The longer list of diagnoses, again, I think it would be important to at least ask the questions and investigate the possibility that maybe the TBI is at play here, and that's why they're having all of these other deficits. Now, they can also have these other disorders which can co-occur with TBI, but it might help modify the way you talk to this individual and develop your goal plan and treatment plans as well around this. I think it's also important to consider the impact that TBI has on juvenile justice populations when we talk about school performance as well, because another risk factor for ongoing involvement in the criminal justice system is not completing school, not being able to have a job. So those are all variables to keep in mind, which would be very important to incorporate into your screening protocol. If you're a law enforcement officer, these are some of the variables to keep in mind. Now, Miranda warnings, do they have an increased risk of really not understanding their Miranda rights? Do they have an increased risk of suggestibility or confabulation, or do they misinterpret the intent of the professional? Is there some confusion going on, or do they have a difficult time understanding commands or even multi-step commands? In some cases too, I've talked to law enforcement officers where the individual would appear intoxicated, but later to find out they weren't intoxicated. Does the brain injury explain that behavior? What about statement reliability as well? I think it's important to be aware of how you ask questions. Are you using yes or no questions versus open-ended questioning? I think it's important to move toward using open-ended questions rather than simple yes or no questions, because it can be a way for the individual to really mask their true deficits. I think it's important to fact check and verify. If you're a law enforcement officer and you're responding to certain populations as well, homeless populations, domestic violence victims and perpetrators, again, juvenile justice populations, and folks with a long history of just criminal justice involvement, you might want to suspect that TBI would impact these populations higher than other populations you work with as well. So just please keep that in mind. As we talk about Miranda rights in a little more detail, I have been unable to find any specific research findings that discuss Miranda rights specific to traumatic brain injury, but I did find one article that talks about it within the context of developmental disabilities, and another article that discusses it within the context of mental health problems. Now, I'm not saying all of these individuals in these studies had a traumatic brain injury, but it's likely that some of them did. And when we think about Miranda rights and traumatic brain injury, I think it's important to ask the question, does the person have any auditory processing deficits? Does the individual have a reduced ability to really understand verbal communication and commands? Do they have any comprehension or sensory deficits? Is the individual sleep deprived? And again, does the individual have a history of confabulation and suggestibility? Very important for law enforcement officers to consider these domains when working with someone and asking Miranda or giving the Miranda rights to a suspect that they suspect might have a brain injury. So some of the important reminders, if you are a judicial professional, a lawyer, consider the impact that brain injury has on the individual throughout the entire trial process. I think it's also important to be aware of legal jargon that you use. The individual may not understand some of the terminology that's being used. So take the time to fact check, verify, re-explain it, and sometimes explain it over and over again. You might also want to consider using developmentally appropriate language. For example, let's say the defendant is 40 years old chronologically. What's his developmental age? Is he functioning at a level as a teenager? Those are all variables to keep in mind. Also, I think it's important to modify and adapt the certain trial preparation modifications, especially if you're working with someone with a traumatic brain injury. The individual may need extra time to be able to absorb the information and process it. You may need to continuously repeat the information. You definitely want to ensure attention's captured when you're talking to the individual, because sometimes they can be very distracted and almost look like they have ADHD, and sometimes ADHD will co-occur with TBI as well. You may need to take more frequent breaks as well. Your traditional defendant may be able to go for an hour. Maybe someone with a TBI will need a break every half hour. It's very difficult to know that without really knowing the individual and screening that individual and preferably getting that individual into appropriate treatment and services. Very important to frequently check for comprehension as well. Again, remember yes or no questions versus open-ended questions. And again, maybe you might want to present information in multiple ways as well. Maybe they have auditory processing deficits, so maybe it's better to write it down or show them and have them demonstrate back to you. Again, every person is uniquely different, but it would be important to maybe present the information in multiple ways. So what about traumatic brain injury and competency to stand trial? There's not a lot of literature out there that help guide competency to stand trial evaluators when they are going through the process with a defendant with traumatic brain injury. There are various types of competency to stand trial abilities and capacities. You might have civil types of competency capacities. I think a very important question is when we talk about this is what's their overall comprehension of the entire trial process? Do they understand the difference between the judge, the prosecutor, the defense attorney? Are they able to participate in their own defense? Do they have the cognitive reasoning to know really what's going on? And can they participate in the defense? Do they know that they have the right to call witnesses? Do they know they have the right to testify or not to testify? And can they really just communicate effectively with their attorney and understand what their attorney is saying to them? There's approximately 50 to 60,000 competency to stand trial evaluations conducted in the United States every year. I don't know how many of those defendants have a TBI, but if you look at the literature related to criminal justice involved populations, again, half of folks in prison have a history of TBI. It's likely that a sizable percentage of that 50 to 60,000 may have had a history of traumatic brain injury. So I think if you're a competency to stand trial evaluator, it would be important to also become TBI informed. This is one article I found that did briefly discuss traumatic brain injury within the context of competency to stand trial evaluations, but it's very important to be sensitive that is there any presence or history of TBI, substance use related cognitive functioning issues, and any developmental and behavioral disorders, because these conditions and disorders are highly prevalent within forensic settings. So again, these are some of the areas of competency, and when we're talking about a defendant with TBI, these would be some of the domains to really consider. Obviously, if you're a competency evaluator, these are the things you do on a regular basis, but if you're a defense attorney, ask yourself these questions when you're working with someone suspected of TBI, and are they able to deal with these and understand them and process? So executive functioning, intelligence, memory, attention are central to the defendant's ability to really be competent and understand what's going on. Now, interestingly, central to someone with a TBI is oftentimes they're going to have issues in these areas. So it's likely to say that some individuals with a TBI are going to have significant issues with understanding their rights and their competency abilities. Now again, attention and memory is a huge factor when we're talking about competency abilities. A huge factor among individuals with TBI is that they have attention and memory problems. When we talk about victimization, again, all of those domains I talked about that increase the risk of someone becoming involved in the criminal justice system can also increase the risk of victimization. So a couple things to ask yourself is, does this person have a diminished ability to really make good decisions? Is there substance misuse at play? Are they consistently intoxicated or using drugs or abusing prescription medications? Are they able to identify and report when they have been victimized? Do they understand that they've been victimized? Have they forgot they've been victimized because of cognitive and memory impairments? Does the person have a reduced capacity to really detect unsafe situations and dangerous people? And again, any type of victimization is typically underreported, But when you have a TBI and all of these deficits, it's likely going to be significantly underreported. If there's a history of intimate partner violence, child abuse, even if the person's had a history of prostitution, it would be important to screen for any history of traumatic brain injury as well. Now, when we talk about confabulation, this is a very important topic that has huge ramifications for anyone in the criminal justice system. But there's some researchers and scholars that believe that TBI, when you sustain a TBI, you might be at an increased risk to confabulate. A lot of people that I've talked to in the criminal justice system are not familiar with this concept. So when we talk about confabulation, think about like this. It's really an unintentional display of dishonesty. There's really no conscious intent or effort to misrepresent the truth. So people who confabulate oftentimes are telling a lie, but they don't realize they're telling a lie. They may be fabricating, but they don't understand or realize that they did fabricate. They might be filling in gaps in their memory. This can obviously jeopardize various legal situations that require someone to really be truthful, be able to articulate memories from the past and not make up a story because they don't remember what the story is. It can impact accurate diagnosis. And consider the impact it has on when someone's trying to communicate their personal, medical, and financial and other sensitive information to various professionals. There's some literature to support the fact that people who are at increased risk to confabulate, especially involved in criminal justice system, may be more likely to provide false or inaccurate witness accounts. In some cases, you might see wrongful prosecution. You might, in some cases, see the individual provide a false confession or a false or incomplete alibi. It could maybe lead to wrongful incarceration. It could possibly lead to ongoing involvement in the criminal justice system. And it's another variable to keep in mind. Does it impact the individual's competency to stand trial abilities? So breaking down confabulation a little bit more, the causes are really multifaceted and complex. Executive functioning deficits may be at play, frontal lobe damage, memory problems. But keep in mind, confabulation can also occur in individuals that don't have any of these issues going on. It's a very difficult topic because sometimes individuals with confabulation can really present as logical and coherent, and their made-up false stories seem very real, very believable. So it's imperative to fact check and verify. Another variable to keep in mind in some cases why people confabulate is maybe they just don't know how to say I don't know, or they don't feel like they have the permission to say I don't know the answer to that. So they make up a story quick, an unintentionally made up story. And as they keep saying that story and thinking about it, now they start to believe it to be true. And now they're reporting that false story as a truth. And if a law enforcement officer is not verifying and fact checking that, that could lead to an arrest where in fact the individual may have had nothing to do with the crime. Breaking it down even further, it's really think about it as falsely constructed answers. Again, they're unaware of the falsehoods of their statements. They generally believe what they're saying is true. In the literature too, it's been called an act of honestly lying. It's inaccurate memories. It can also be taken out of temporal context. A good example of this would be if someone reports that a memory that happened yesterday, later to find out that memory happened 20 years ago, but they believe it happened yesterday. The memory's true, but taken out of temporal context. Provoked confabulation is probably the one you're going to see the most in the criminal justice system. This is a result from direct questioning. In some cases, you may see it spontaneously occur, but more times than not, you're going to see provoked confabulation rather than spontaneous confabulation. If you're wanting to learn more about this topic, these are some of the overlapping terms you may see in the literature, so I'd recommend doing some basic searches on this. I'm always asked, how does confabulation present? I mean, it's all over the map. It can, again, sound very convincing. In some cases, it can very delusional. They can be very detailed. They can be normal. Is the person fantasy prone? I think that's a very important element to consider too. Those who are more fantasy prone may be more likely to confabulate. So if someone with TBI who's looking at social media constantly and is very fantasy prone, what's their level of exposure to social media? What's their level of exposure to various kind of role-playing games? Do they believe in fantasy, and do they come to believe that to be true, and do they act it out? Do they have a behavioral response to that too? Again, I think it's also important to really hammer this home is, again, what if you're a criminal justice professional, really what sometimes appears to be a deliberate lie may in fact not be. Are you dealing with someone with confabulation? So the more you can learn about confabulation within the context of traumatic brain injury, I think would be very helpful too. So how do you address it when it does occur? Again, you want to fact check, you want to verify, corroborate the information. It may be important to refer this person out to a neuropsychological evaluation. I think it's important to review multiple data sources as well. Not just take the individual self-report. Again, look at records, talk to family members, talk to people who know this person well. After the brain injury, did they start confabulating, or did they have a history of confabulation prior to the brain injury? All very important things to consider. If you suspect confabulation, I think it's important to also document it in the individual's case file so there's a documented history so other people who are working with this individual can hopefully review those notes and maybe alert everyone that you might be working with someone with an increased risk for confabulation. So as we move into some of the concerning and problematic and criminal behaviors, anger, aggression, and violence can occur as a result of brain injury as well. You might see it referred to as post-traumatic aggression. You might also hear it referred to as post-traumatic irritability. And this may be as high, you might see post-traumatic irritability as high as 70% of cases of TBI. I've seen this happen where I suspect misdiagnosis may occur, where I've seen someone with a history of TBI get diagnosed with bipolar or intermittent explosive disorder when in fact it was likely the symptoms of the TBI that resulted in that misdiagnosis. Some of the other variables to consider: is there a history of untreated mental illness when we talk about anger, aggression, and violence? Any untreated or unaddressed trauma? Does the person have chronic sleep issues? I've worked with many clients that sleep 2 hours a night and they've slept that way for years. What's their level of self-shame? What's their level of substance misuse as well? You may also see the individual, it might present as just a loss of emotional control. You might see them even be very stubborn. They might have like childlike temper tantrums in some cases. I've had a few clients that will make very inappropriate statements in social situations where they're just not aware of their surroundings, or they just don't care of their surroundings and will start yelling and swearing. Do they have inappropriate interpersonal sensitivity? Do they go up to someone who is crying and start laughing at them and making fun of them? And then what's their level of impulse control problems as well? Sadly, traumatic brain injury, some of the deficits and the co-occurring disorders may increase the risk of suicidal behaviors as well. These are some of the variables to take in mind. I think it's important to ask the questions too, is did they have a loss of family or support system after the brain injury? Did they lose a job? Did they lose their career? Were they no longer able to function and stay in school? Can they no longer manage their daily affairs? Again, this could lead to guilt, self-shame. Is there a relationship failure? Are they going through a divorce? Is there a custody battle going on? Are they able to parent effectively? What's their relationship like with their kids after the brain injury? These are all things that possibly could lead to an increased risk of suicidal behavior as well. Lack of supports and services, I think, is a huge one. Is there loneliness, isolation? Do they have a history of homelessness? Mobility issues too, I think that's important to consider. If there's chronic pain involved and they're not able to get around and just do the things they used to do, obviously that could lead to an increased risk of depression. I've seen them use lots of alcohol and drugs just to cope with the pain, and they just want to block it out. Juveniles, in some cases, do they have a history of being teased and bullied? So I think it's very important to screen the individual for any possible suicidal behaviors and even self-injurious behaviors. What about alcohol misuse? Another variable to consider. Again, I've talked about this, but TBI and alcohol, a lot of cases are a direct result of being intoxicated and poor choice making. Interestingly, depending on the research you read, anywhere from 44 to 79% of individuals with a TBI may have a history of misusing alcohol in the past as well. Again, with untreated mental health issues, is there any untreated trauma or post-traumatic stress disorder and depression and insomnia? These are all things that can just exacerbate this problem as well. Consider the impact of ongoing involvement in the criminal justice system. Or if they're on probation and they constantly are using alcohol or other substances, is that in violation of their probation? So I think it's vital to find a therapist or a day treatment program or a treatment provider who is traumatic brain injury informed, who also takes into account the other mental health and substance and alcohol use disorders. And consider if someone already has a traumatic brain injury, is abusing alcohol, does that put them at an increased risk for falls or accidents or other injuries? Yes, it absolutely does. Substance misuse disorder is very similar to alcohol, but again, it could increase the risk of ongoing traumatic brain injuries and ongoing involvement in the criminal justice system. Could it be a result of self-medicating and just trying to forget the problems? Definitely trying to just forget about their body pain. Consider the impact on post-release planning too. If someone has a history of substance misuse, getting treatment providers in place before the person leaves the correctional setting and getting them into the supports and services they need with a TBI-informed treatment provider is highly recommended. So risk-taking behaviors, I've seen it all over the map. Someone with a long history of traumatic brain injuries, multiple head injuries, I've worked with a number of people that can be very impulsive with money, or just engaging in inappropriate sexual behavior or risky types of sexual behavior. Consider the impact on their driving abilities. Are they a safe driver? Does it run the risk of them becoming more violent or aggressive or getting into more fights? What's their history of thrill-seeking behaviors? Did they have a history prior to the TBI, or did they have the TBI and now they have a number of thrill-seeking behaviors? Consider impulsivity and then cause and effect, and just really overall executive functioning deficits as well. Interestingly, I've had a number of clients too I've worked with that with a TBI who are just unaware or unwilling or just not able to really be aware of their limitations. And then consider the impact on ongoing risk for additional traumatic brain injuries. So as we move into other types of criminal behavior, intimate partner violence and traumatic brain injury is a huge issue. There's quite a bit of research articles on it. If you're working with a victim of domestic violence, if you're working in a domestic violence shelter, I think ongoing and regular screening for TBI is highly recommended. I think it's important to ask the individual questions is, have they ever had injuries to their neck or face or head? Have they ever lost consciousness? High percentages of individuals may report yes. In some cases, they may not remember, they may not know. There might be a lot of fear, shame, guilt, and stigma. Consider their neuropsychological problems too, the impact it has on them being able to accurately report information and go to treatment and get the help and supports they need. Consider, again, attention, learning, memory problems. It is an under-identified problem because sometimes they may hide or minimize, or they might not go to the doctor after the head injury because they're just afraid, or they don't want to lose their family. They don't want to get their partner in trouble with the law. And in some cases, routine screening may also provide relief to some of the survivors because they may not be aware of why they do all these behaviors and why they have these various deficits. Once they learn that maybe it's a result of traumatic brain injury, it's not their fault, that would help them release some of that guilt and shame, where they'd be more willing to go get some of the supports and services that they desperately need. Again, routine screening, again, look for the red flag indicators, and then keep in mind the high percentage of substance misuse. If you are in a domestic violence shelter and you work with this population, does the person come in with a lot of confusion, or do they seem disoriented, or just as you get to know them, is there a lot of out of character behaviors, or do they just seem very tired and lethargic? Again, it could be a result of trauma and depression, but also it could be a result of traumatic brain injury as well. Impulsive behaviors, needless to say, again, it's a major issue. Consider the impact on controlling one's behavior. Does it increase the risk of aggression? Does it impair their judgment? How does it impact their just overall problem-solving abilities? Are they self-aware of their surroundings and their behaviors? In some cases, I've seen it too, they might have a low threshold for stress. So if they're not able to manage their stress, they might be more likely to get into fights. They might be more likely to misuse drugs and alcohol, which could put them at greater risk for another traumatic brain injury. And if they're in the criminal justice system, it runs the risk of them becoming violated on probation or possible additional charges as well. Antisocial behaviors, a large percentage of people in the prison system also deal with various antisocial behaviors. Antisocial behaviors may increase the risk of traumatic brain injury. I think it's important to ask questions too, is again, have they ever had a history of gang involvement? If so, have they been in fights? Have they been hit in the head? Was there any fire setting behaviors too? I think that's important to consider. In domestic violence, has there been any sexual related offenses? And then their juvenile justice record. If you start looking at these patterns and you start understanding the red flags and the symptom indicators, some of these things would really start sticking out to people that might trigger you to send that person for a more in-depth assessment or even a neuropsychological evaluation to really understand this person's functional capabilities. And when we can do that, then we can develop TBI-informed goal plans and interventions and treatment plans to really help this person succeed. So as we move into the correctional system, a lot of the variables we've already talked about can be applied to incarcerated populations with traumatic brain injury. But again, other key variables is any alcohol or substance misuse. When you have that ongoing, it's important to learn about their level of impulsivity and antisocial behaviors. And when you see that pattern emerge, it's important to ask questions about, have they ever been hit in the head? Have they ever been knocked out or lost consciousness? All of those things would be very important. If a confinement officer, a corrections officer, or even a probation officer does not understand traumatic brain injury, once you start understanding it, I think it would be very helpful to really keep these variables in mind. Does the individual have poor communication skills? Does the TBI better explain why they have a difficult time communicating their thoughts effectively? Do they often misinterpret what you're asking of them, or even your verbal commands if you're a confinement officer, corrections officer? Do they do this on a regular basis? Are you dealing with the same group of individuals over and over and over again? Are they having multiple behavioral infractions and management difficulties? And just, you notice lots of memory issues. They ask questions over and over again that you keep explaining to them. Those would all be very major red flags to keep in mind, that maybe you're dealing with an inmate that has a traumatic brain injury. So the way you're communicating with them might not be effective. So utilizing some of those TBI-informed approaches might help this individual be more successful in prison and help them be more successful as they integrate out into community as well. Not as much research on female offenders and traumatic brain injuries, but what research is available is that traumatic brain injury among this population may be even higher than male populations, and some of the reasons relate to domestic violence victimization, child abuse, sexual abuse histories. There's definitely more research that's needed in this area. When you're working, with female offenders with a history of traumatic brain injury and male offenders with a history of traumatic brain injury, I think it's important to at least have a general understanding of the ACEs research, adverse childhood experiences research, because such a high percentage of this population has experienced various forms of trauma as well. Earlier I said it's important to become trauma informed. I think it's vital when we're working with this population to be trauma sensitive as well. So when we're talking about release planners and reintegrating into the community, inmates with TBI face many barriers, and some of them would relate to healthcare. Do they have access to healthcare? Do they have insurance? Transportation needs would be a huge thing. Employment and housing would be two of the biggest variables, because if they have a felony record, obviously it makes it more difficult for them to find a job and find appropriate housing. So those are all services and supports that I would highly recommend getting in place prior to the individual being released back in the community. Getting the family involved, getting family education involved, educating the individual about TBI, having realistic expectations as well that are developmentally appropriate, that can be very concrete, utilizing skills building approaches as well, like teaching, modeling, coaching, role playing, those kind of things. And I think it's also important, in a lot of these cases, long-term supports will need to be in place, and in some cases, lifelong supports as well. The individual may need to be establish connections with case management or an independent living skills worker or a vocational specialist or a housing worker or a psychiatric rehabilitation specialist, a psychiatrist, therapist. All of those providers I would encourage to really become informed about traumatic brain injury as well. There have been a few studies that have been done on traumatic brain injury in death row inmates. I listed the full citation here for any of you that want to read these. These are older articles, but they still provide good information about the topic. This is a recent article that came out in 2013 as well that I'd highly recommend reading. I think it's a good article that just talks about various brain traumas and within violent prison populations. So some of the important reminders to take into account if you're a corrections professional, again, I think if your agency, if your department, if your organization allows for it, routine screening for TBI. If right now they're not equipped to do that, find a way to eventually become equipped, become more informed, learn about the various screening tools, take as many trainings as you can, consult with various experts in the field. And you might need to modify your intervention and treatment approaches, the way you communicate again. And just, I think memory monitoring is a huge thing too. A lot of times they're going to have a hard time remembering from session to session, from meeting to meeting, from group to group. Keep that in mind. And I think a big thing too is being aware that in some cases, inmates with TBI may be at a higher risk of victimization because of the very deficits sustained from the head injury, gullibility, suggestibility, the memory impairments, all the things we've talked about. So as we move into screening, there's a lot of benefits of screening. I think obviously we can make more informed sentencing recommendations and considerations. I think it's important if we know someone has a TBI, it can help better inform the release planners and develop those release plans that are going to be more TBI informed. I think it's really going to help identify at-risk individuals and provide them additional supports that hopefully would reduce risk of peer victimization. I think we can match the language we use to their developmental and cognitive functioning abilities too, if we have a better idea of how their brain injury actually impacts them. Under recognition of TBI can lead to a host of issues. I think it leads to a lot of mislabeling and just misperceiving the individual. So if you're working within a forensic setting and you're working with an inmate that just appears disorganized, often is very impulsive, they seem immature and lazy and non-compliant, they don't show a lot of remorse, and they can be callous, and they're laughing at inappropriate times, and they seem indifferent. In some cases, I'm not saying all, but some cases, do these behaviors, are they better explained by a possible traumatic brain injury? And keep in mind too, if you're not treating the brain injury, they might have more adjustment issues within the prison setting as well. This is outside of today's presentation because of time, but these are some of the related screening tools that you'll find in the literature. One of the more common ones and very quick, easy to use screening tools is the HELPS. I would recommend all of you doing a Google search, just becoming briefly familiar with some of these. Find out which ones work for you. Learn about these tools. Most of them are pretty easy to use. Some of them require more training than others, but I would recommend at least checking out the HELPS. If you Google that, you'll find the PDF download of that. So intervention and treatment considerations as well. Early intervention, I think, for this obviously is key. Unfortunately, that doesn't happen in most cases. I think it's important when we are working with criminal justice involved populations with a history of traumatic brain injury, it's important to use direct language. So be very concrete, use clear language. This could help minimize the risk of miscommunication. Consider using open-ended versus closed-ended questioning. Again, remember the yes or no versus the open-ended questioning. Keep the pace of the conversation slower. Maybe the lights need to be dim. Be aware of the sensory issues. You might need to accommodate their needs. So keep in mind, what are their needs? Do they have sensory issues where bright lights bother them? Does the pace need to be slowed down? I have a client right now I work with where I ask her questions. It takes her sometimes 7 to 15 seconds to respond to a question. It just takes her longer time to process that information. So look at that, adapt your approach, slow things down. I think a key component too is on the professional's part to just remain patient, utilize motivational interviewing tactics, non-shame-based approaches. Most of this is common sense, but I think it's a good reminder. When you can, engage the support system as well. Does the person have a legal guardian or a conservator? Get family members involved. Is there a mentor in place? Get their treatment team, case management team together. The more everyone can be together and talk and consult and have one goal in mind or one treatment plan in mind, I think that's going to lead to better outcomes when possible. I know that's not always possible, but strive for that if possible. These are some of the other outcomes that might help just improve overall functioning for individuals with TBI. I think a big one is offender education, again, caregiver education, family education, and professional education about traumatic brain injury. So everyone who is dealing with the brain injury, including the individual, really have a better idea about it and how it does impact their day-to-day functioning. So what have I found that's worked? I'm asked this too. This is just from my experience working with lots of individuals with confirmed or suspected TBI. Some of this I've covered, but I think a good review, good reminders. It's important to keep in mind, allow the individual extra time to process information. Try not to overwhelm the individual with tons of questions or multi-step questions. Keep it as simple as possible. I think it's important for all of us to remember it's okay with long pauses and silence. Remember, my client sometimes takes 15 seconds to respond to a question. Be okay with that. Take the time. Don't rush the individual. Utilize encouraging approaches. Frequently check for comprehension. I always try to use non-confrontational approaches. Really try to be patient. Reassure the individual. This is a big one too. Reassure the individual. If they don't know the answer to a question, it's okay not to answer it. This might reduce the likelihood of them confabulating in some cases as well. Again, I think it's important to use developmentally appropriate language. Again, you're working with someone who's 40 chronologically. Developmentally, are they 15? Are they 18? Are they younger? And then just fact check and verify the information being provided. This is more geared toward individuals with memory problems, but I think it's important consideration to take into account too when we're talking about traumatic brain injury. is they might need a memory diary. I encourage folks to always write things down for the individual, but I encourage the individual to write things down too. Really practice memory monitoring. Self-monitoring training is another technique where it teaches the individual really to more effectively monitor and evaluate their own behavior and treat their associated symptoms. If they're dealing with anxiety, depression, insomnia, treat that as well, because some of these symptoms may be improved when you can treat some of these co-occurring secondary disabilities. So as we get close to wrapping up today, some of the key reminders when we talk about what works, what should we try, is try to be consistent. A lot of times the clients I work with, they might have 5, 6, or 7, in some cases, different providers that are working with them. The more these providers can communicate and work as a team and be consistent, the better. Keep things concrete. Demonstrate for the individual. Model, coach, teach. Long-term approaches, and in some cases lifelong, and then utilizing developmentally appropriate language intervention techniques. I appreciate all of you tuning in for today's webinar. If you have any other questions about today's webinar, here's some additional contact information for me. I also encourage you to look at our website. And these are some other websites I put here that have some free information on there if you're interested in some of the topics we just spoke about today. Thank you again, everyone.
Thank you, ladies and gentlemen, for watching our webinar presentation today. Also, a warm thank you to our presenter, Jared Brown, for a wonderfully informative presentation. For more information on AIAFS and to see upcoming and available webinars, please visit our website. You can find the link in the description below. As a thank you for being a professional friend of AIAFS, we also wanted to give you additional resources. We are including a link in the description below to access free online articles through Forensic Scholars Today. We also want you to have the opportunity to be the best version of yourself by furthering your education in earning a Master of Arts degree in Human Services with an emphasis in forensic behavioral health. AIAFS has proudly partnered with Concordia University St. Paul to bring you an 18-month, fully online master's degree. For those of you who already have a graduate degree, you can earn a Forensic Behavioral Health graduate certificate in as little as 8 months. Direct links to this program are included in the description below. Once again, thank you so much for watching. Have a fantastic day.